is The Last Word.
Good evening and welcome to The Last Word right here on NTV. Tonight, we want to have an interesting conversation. Now, we know what's been in the public domain. The issue of Ebola, the outbreak in the DRC, Eastern DRC, crossing over into Uganda, and the fears that it may cross over into Kenya, surveillance, monitoring, and also the entire debacle about the Laikipia Air Base facility, US funded. Now, we want to discuss this from the angle of whether Kenya is indeed prepared for an Ebola outbreak. What would happen if one of those surveillance areas in this country actually showed that there is a confirmed Ebola case? Is Kenya prepared for an Ebola outbreak? For that conversation, we want to have experts in the room, plus citizens who are with us. Professor Wallace Bulimo is a molecular virologist and Ebola coordinator at the Kenya Medical Research Institute. Peterson Washira is the chair of the Kenya Union of Clinical Officers. He and others went to Sierra Leone when there was an outbreak in 2004 to 2006, 2014 to 2016 rather, in West Africa, Sierra Leone, Guinea, and Liberia. That was a huge, devastating outbreak then. Kenya contributed healthcare workers to go and help deal with it in West Africa. They came back, they're here. Do they have the experience that is needed to actually handle it? When you talk about Prof and KEMRI, what kind of capacity does KEMRI have in the country? That is the conversation tonight. My name is Eric Latif, and I'm here with James Smart.
Absolutely, Eric. I think we have experts tonight. And maybe we just get the feelings out of the way first,
yes,
before we get to the science aspect of it. I think there are two questions to consider here. One, which is what Kenyans have raised. Ebola since 1979, I think. It's never crossed over to Kenya. There was never fears of Ebola coming to Kenya.
I wonder why.
Not once. But finally, for some good, gracious reason, there could be Ebola fears. And we have experts who can help us to deal with it. So I think those are two separate things, but I said feelings out of the way.
Yes.
I think it's important for us to address the science, which is to give the public, I think, the accurate information of what is actually what we are capable of as and when, if it were to happen, but also the politics around it, which is also why we're here. We won't be discussing this in all seriousness if that facility in Laikipia Air Base, the American funded, was not, quote unquote, accepted by Kenya. I think that is the truth.
What is the emotion around the American facility? What is the issue, really? If from sitting and listening to all the concerns that come, even the petitions that have been lodged in court, what is the main bone of contention?
I think precisely the first case, I think last week, it mentioned that first, Kenya does not have the facilities to deal with Ebola for Kenyans. So if Kenyans, God forbid, were to have an outbreak, Kenya does not have enough facilities to deal with it for Kenyans to begin with. And the judge accepted that and said, look, we need to first preserve Kenyans. The Constitution talks about we the people, Kenyans, should be the first to be considered in any eventuality. Okay. And that's both a political and a governance question. Okay. The second, of course, is what the president enumerated yesterday, that huge part of Kenya's health budget really is facilitated and assisted by the Americans. Yeah. And so in this case, Kenya felt the need to help and assist the Americans in this quest. Those are two separate things. But I think the emotional point of it, which Kenyans, and it's a point that Ebola has been there since 1979, there was never fears, never even one headline, until last week, that Ebola fears coming to Kenya. I think you can put two and two together.
Are they well-founded or not? Now, we've heard from the Union of Doctors, Pharmacists, and Dentists, right? The Union of Clinical Officers, what is your position on this, Peterson? Are the clinical officers as concerned as doctors when they came out with their statement?
Thank you, Latif. And this is a very important conversation that we are having today. So the Kenya Union of Clinical Officers has the benefit of having an expert. And the route we chose was, Ebola is not going to ask the question of whether we have the capacity or not. And if we don't have the capacity, it waits for sometimes for us to have capacity. If we have it, then it comes into the country. If Ebola is coming into the country, which it may, and I hope it doesn't, then we do not have the laxity of time. We don't have the benefit of time to prepare. So we have given an advisory from the lessons learned, and I know that the ministry is acting on it to ensure that we have the capacity, because we must unbundle the conversation. Because the conversation, there are too many parts of the conversation. There is the quarantine center, there is the bilateral agreements, there is the political side. And I think as experts, we really do not want to delve into the murky waters of politics.
You don't want to be caught up in that.
Yeah, we want the politicians to do that. For us,
but you see, are you suggesting doctors?
It's not politicians.
Yes, because doctors, are you suggesting they are uninformed and they don't care about the science, they don't care about anything else?
No, that's not what I'm saying. What I'm saying is that there are many paths to a destination. And I think the path that we have taken and the path probably they have taken, I'm sure what they are trying to achieve is the same thing, that we have the capacity. And so we have come together as experts. We have over 100 who are retained. And by the way, we did not just attend to the 2015 outbreak and went back home. We are retained by the African Union, Africa CDC, as Africa Volunteer Health Corps. We are inducted from time to time. I was in Burundi in 2024 for an induction, and my colleagues also have been inducted. In 2019, around October, there was another scare, if you can remember.
Yep.
And we were still deployed to the POEs, the points of entry. We have also been active during the COVID-19. And so I think that is the reason that we thought that for us, why don't we give an advisory and follow up on the advisory? And if then we see that the ministry is not willing to take up the advisory to protect citizens and also to protect the health workers, then we will be able to take other steps.
Okay.
Yes.
We'll come back into that, but I just want to, I see everybody has a board. So in that board, I want you to express your opinion as loudly as you can with the board.
Emotions
Green is yes and red is no. Is Kenya prepared for an Ebola outbreak? Green, yes. Red, no. There's green on that side, there's red on the other side. Right? So I see, and I can guess that the people who are saying we are adequately prepared may be people who have inner knowledge from the profession and practice. The people who are feeling that Kenya is not adequately prepared, what's the
basis?
Yeah, what's the basis of your feeling? Let's start with you. You have the mic. Tell us your name and why are you voting no?
Okay, my name is Honorable
Please
Francis
put the microphone
Owino.
next. You want?
Like?
Yes.
This way.
A
Thank
bit
you.
closer.
Oh, okay.
A bit closer.
Oh, this
Yes.
way. Thank you.
Yeah.
Okay, my name's Honorable Francis Owino. And on my own understanding, as a young politician in this country, I think Kenya is not ready for this devil. Let me call it devil, because what it is doing in other parts of Africa, like Congo, Uganda, especially Congo. There's a video I watched yesterday where there was a guy, he died because of Ebola. And then, a country like Congo is, the disease started there a long time ago. I think by then, they could have been prepared for it. But as Kenyans, I think we are not ready. We are not very ready. Yeah, although the government, it has increased surveillance areas, border screening, laboratory testings, emergency response measures, challenges such as limited resources, and the need for continued preparedness. What I can say is, I think for Kenya, this involved money. Okay, when US poured $13.7 million in the country, now there are loud voices, for this thing. There are a lot of loud voices for this thing, of which I know very well it's all involved money.
Okay.
Yeah.
So you're just seeing the money bit here. Pass the mic behind you and let's hear from the gentleman and then the lady.
Let me introduce myself as a son to Joseph Onyango.
You are a son to Joseph Onyango?
Yeah.
And what is your name?
My name is Dennis Omondi.
Okay. Thank you for clarity.
So mine is just to say that Kenya is 100% not prepared. Number one, because it's the first time we are tackling this Ebola issue. And then if you check on the workers, we don't have those workers who are skilled to handle this Ebola issue. And then number two, the question is, are we having enough containers for the sanity of Ebola? Then the other thing is about shortages of workers. Do we have those enough doctors who will cater for this Ebola workers? And then number two, the place, let me say like Kipia, we have, Kenyans, when we see the Wazungus, we get attracted. So I think it won't be fair enough that they select Laikipia as the center, because most of the Africans might temper with the Wazungus. Then you see all those. Then number two, we have heavy international travelers in and out of the country. Then finally, who will fund all this? Because I think the 1.7 billion, it's for the setting up. Then the question is, if the Ebola transmits to the Kenyan citizens, it will be more expensive than the amount that the US has offered to Kenyans. So I think it's not right.
So I think we're not ready. Pass the lady. Let's hear from the lady. Pass to the lady first. You voted no. Yeah. You think Kenya is not prepared for an Ebola outbreak. Tell us your name, please, and why you think so.
My name is Alisa Ofula. First things first, looking at the Kenyan medical scene, we struggle with very many things. Issues like malaria, for example. We still struggle with that, yet we're choosing to focus on other things. But again, we can't turn a blind eye to Ebola, because we have many Kenyans moving in and out of the country, which means they're also exposed to this thing. So at the end of the day, we still have to, take the necessary measures to be prepared for it if it comes into the country. But I would say that we are not prepared as Kenyans, because we have bigger issues that we need to focus on first before we can move on to other things that haven't even yet gotten to us. That would be my point of view.
What would preparation look like to you?
First things first, it would look like, educating the healthcare workers we have in Kenya. They haven't really been exposed to Ebola. The diseases we have majorly in Kenya are like things like malaria. So educating them on this disease like Ebola, what are the precautionary measures, what are the steps to take? I would say that.
Okay.
All right. I'd like to hear Prof first, like it's a bit of science before we come here, as to give us a proper grounding of what Ebola is and what it is not, as you also the question of how prepared we are.
So, Ebola is a viral hemorrhagic disease.
Prof, sorry, just for benefit of our audience, just introduce yourself.
Okay, my name is Professor Wallace Bulimo. I work for the Kenya Medical Research Institute. I am a molecular virologist, and currently I serve as the coordinator of all the response of Ebola response in KEMRI. And KEMRI is a major stakeholder amongst the people who respond, or amongst the institutions that are responding to Ebola in this country. So I come here to represent the position of KEMRI, and I want to talk about what Ebola is. It's a disease that's caused by a virus that causes many symptoms, but key amongst them is grouped as a viral hemorrhagic fever, which means you get fevers when you are infected, and at extreme ends, sometimes you get bleeding from all manner of places in your body. But it doesn't just do that. It makes you feel weak. It makes you sometimes diarrhea. It makes you cough, vomit, and all other things. So sometimes in the initial cases, you may not tell the difference between Ebola and other common diseases. And that's why it's very important for us to be able to test this in the laboratory and confirm that it's actually Ebola. But there are some telltale signs that will really lead to us to be able to tell if there's a high suspicion that you're infected with Ebola. For example, if you're coming from a place that has already been associated or linked to Ebola, or if you have a recent travel to a place where people had it, or if you come in and then you have other things that will indicate that you may have Ebola, for example, the bleeding. So once it is tested and it is proved that you are Ebola, then we say you are a confirmed case. But before that, if we associate you with where you've come from or whom you've contacted before, if they had been in a place where there's Ebola, we say there is high suspicion, so you're a suspect, as a case of suspect, or an Ebola suspect case. Ebola is a serious disease because it has high mortality. It will cause mortality between 30 to 50% of the people that it infects, depending which strain you get. But it is not a disease that will kill all people. We've heard of cases whereby people have actually recovered. And I'm not saying this to indicate that we should lower our guard because of the fact that only maybe 30 to 50%. You can imagine if 30 to 50% of Kenyans died. It's a serious disease that we need to take very seriously, and therefore I think that's why the government and everybody is talking about this, and from the highest office in this country to the rest of us, we are talking about it because we know it has many consequences beyond just the disease it causes and the problems it causes to the families. It has economic impacts. It has biosecurity impacts. It has health security impacts. So all these things make Ebola a disease that we need to really look out for. But we should not be worried, or we should not really panic about it. We should just follow the preparedness that we have, because we know once you are prepared, then you can deal with any problem that comes your way.
Prof, I want to ask, you've mentioned about the strain and this different strain. What do you know about it and how is it different from the other strains?
So there are a number of strains of Ebola virus. There's those which cause severe disease, and there are those which cause really no disease. So some of the ones that cause disease is like Ebola Zaire or Ebola Sudan, and now this current one, which is called Ebola Bundibugyo, it also causes severe disease. There are other strains, including, for example, the Reston, Ebola Reston, which, in fact, you might get it and you might not even show symptoms. So what we're talking about is that depending on which strain you've had, you're infected with, you can either have no disease or you can have severe disease. So unfortunately for the current strain, it's one of those that causes severe disease, Ebola Bundibugyo, and therefore we should be concerned about it, but not panic.
So, Prof, people are saying, you know, just like Smart was saying earlier, well, since the late 70s, we've had Ebola cases, outbreaks. Outbreaks have been there in our neighboring countries. Never a single case reported in Kenya, you know? But this time, why are we acting like we are trying to import cases into Kenya?
Thank you for that. I think we need to look at the connectedness of the world today and in the past. I can take a plane from Nairobi here and be in Uganda, Entebbe in the next 30 minutes. They could also take a plane from Entebbe, and be in Nairobi in 30 minutes. The kind of trade routes that we have, you see, we know our truck drivers transporting things from the port of Mombasa to Uganda, DRC, Sudan, Rwanda, and the rest of the countries. It takes maybe within 72 hours, you've really crossed many borders. So it has become very easy because of the transportation pathways that we have right now to be able to move. Ebola, we know that it will, if you get infected with the virus, you will show symptoms, or you'll show symptoms between 2 to 21 days. And all these places between Kenya and DRC Congo and any of these places we are talking about, you don't need 21 days to cross. Okay, we have mechanisms of freely moving around very quickly. So that's part of the reason why we need to be very aware that what is happening in Kinshasa today might be here tomorrow because of the ease of transportation and the ease of movement and the need for trade and other things like tourism. You don't know who will come and how soon they will get to us, and therefore we can get infected very easily.
Thank you, Professor Bulimo. We'll come back after this break and also hear from the others. We have some people who feel that, yes, Kenya is actually adequately prepared for this. Those who feel that Kenya is not adequately prepared. And also, we'd like to hear the experience of those that went to deal with Ebola outside of this country, into West Africa. Do we have proper trained medical professionals in Kenya who can handle Ebola? This is the last word. Is Kenya prepared for an Ebola outbreak? That's our question this evening. We'll be back shortly to discuss more. And we're back. This is the last word. We are asking ourselves, is Kenya prepared for an Ebola outbreak? We've asked that question and the room has half-half. There are those here who said, we do not feel that Kenya is prepared for an Ebola outbreak. And when you ask, do we have the requisite medical personnel? Do we have proper training? Do we have facilities that can deal with Ebola? Can we even test Ebola in this country? Those are the questions that are being asked. The experts who are here from KEMRI, the Union of Clinical Officers and others are positive about it, right? How do you balance this?
A question of feelings, governance, and I think competence. And I think it's unfortunate that we are locked in this conversation because it is unfair to ask, I think, the scientists if we are prepared. Of course we are prepared. Again, the training that you're talking about, going to Libya and Liberia. In Liberia and the rest of it, it's competent training. So I think the question is not doubting our expertise or the science. I think, unfortunately, we are caught up in a moment where a decision has been made that has invited a global conversation, because if you look at it, I checked the heat map on Ebola. Kenya is discussing Ebola more than Tanzania. Why? Does it mean Tanzania does not have the same fears? So we are caught up in a different conversation, unfortunately, but we have to discuss it. But you have a comment to make. Please introduce yourself.
Thank you very much. My name is Akom Mutunga. I'm an epidemiologist. I want to talk about our traveling to West Africa during the 2015 Ebola outbreak. There was an outbreak in three countries, that is Liberia, Sierra Leone, and Guinea. And this happened after review of the data there, it appeared around 2013 December, but it was detected well in 2014. We went there in 2015. That was like 1 year down the line. Then Africa, let me start with the preparation for Africa now. Africa did have a way of responding to outbreaks. So they didn't have a legal framework to send civilians, medics, to go to another country. But they had a legal framework to send military intervention. So we were given a general from Uganda military who led the mission. So I was in Liberia, and we landed in Liberia. Now, Liberia, Liberia had some political instability at some point. From 1980, there was a guy called Samuel Doe who overthrew the government. Then 10 years later, there was his government was overthrown. So they went into a turmoil of political instability that affected the workforce and also the surveillance system. So if I make I compare, this country has never gone through that. I started responding in 2009. I was in Iraq during the Operation Desert Storm, and I responded to H1N1. I was working there I was not in the military, but I was working there. So, given these countries which have Ebola, the first Ebola case was diagnosed in 1976 in Zaire. Actually, that's why the name Ebola. Ebola is a river somewhere in Zaire. That's where the name comes from. If you look at that country, even to date, they still have political instability. So these political instabilities affect many things. Among them is the surveillance system. If you look at Uganda, Uganda is a good working in terms of response, because they have been hit by. Actually, the Uganda strain was 2007. So they have been handling well Ebola. If you look comparison these countries now and Kenya, Kenya, we've never gone through this turmoil. So our system is very sensitive. We have the workforce. That's what I can just say about in comparison with these countries. Now, if you look now to the Africa as a continent, our going there in 2015 brought the African CDC. Actually, it was formed in 2017. We are all here, AVOC, the African Volunteer Corps. We are in the database. So if in Africa something happens, like it is so emergency, we have the workforce first from the Africa CDC. Then now, when it comes to Kenya, I think we have the best guys.
How many Kenyans went to address this in Guinea, Liberia, and Sierra Leone?
We were a total of 171, and 93 were in Liberia, and the rest were in Sierra Leone.
171 Kenyan medics, right?
Yes.
So from what cadres?
They ranged from clinical officers and medical officers, epidemiologists, lab scientists, psychosocial support, because there's some element of mental illness, even to the healthcare workers. So it was a range of many cadres. And we went there January 6th, and by May 9th, we declared Liberia Ebola free. So with all those shortcomings which were there in terms of surveillance and also the infrastructure, the health infrastructure.
Okay. Among the questions, and you can pass the mic to the gentleman at the front, among the questions that I'm hearing people asking here is, do we have the facilities? Right? So yes, we have surveillance, but are our hospitals, our health facilities well equipped to actually tell that this is Ebola? And if there is Ebola, can we handle a rapidly spreading viral disease like Ebola? So
Thank you very much. Maybe just introduce myself. Victor Full is my name. I work as a senior research scientist in the Arbovirus and Viral Hemorrhagic Fever Laboratory in Cambridge. Actually, one of the laboratories that have been designated to be testing these viruses. When it comes to level of preparedness, in terms of diagnostics, I would say that we are okay. We have the capacity to test for the virus. We have the capacity, we have the personnel that can actually test for this virus. The first time...
Across the country?
Well, not all labs can test for this virus because just as Prof mentioned that this is what we call BSL-3, BSL-4 pathogen. And so only laboratories that are designated or designed as BSL-3, BSL-4 can test for that. And we have probably about 6 in the country. Cambridge has from the coast in Kilifi, Kericho, Kisumu, and Nairobi that have the capacity to test for this virus. So back in the year 2000, I think that was the first time that Uganda had an Ebola case. And some of the things that you're seeing happening now were actually happening back in the year 2000. In the year 2001, some of us had the privilege of being trained in Atlanta, CDC Atlanta laboratories, to test for those viruses. Not just Ebola, but a couple of other viruses that can cause severe disease in humans. And so when somebody asks, do we have the capacity to test for Ebola? We have the capacity. We trained 2 people back then, but right now in the country we have probably more than 40 people who are trained because we pass on the skills to the other people. So we have the capacity to test. Now, for the health facilities, what is happening right now is that we have trainings that are going on, conducted by staff from the Ministry of Health to train people on surveillance, screening, contact tracing, a couple of things. So the skill is being passed on. It's been happening a couple of times, and whenever there is such a threat, we have rapid response teams that are formed and with the ability, with the skills to tackle such kind of an eventuality. So when it comes to the health facilities, we might have some of the health facilities that will be selected as isolation centers, like quarantine areas, and we call them ETUs, Ebola treatment units, that can also be set up in case there's anything that has been confirmed. So as it is, we have health workers who are being trained to respond to this outbreak. So I wouldn't say that you're badly off, but guys are just preparing in case anything happens. Yeah, thank you.
I think it's very comforting to hear this. Yes, please pass the microphone to the back. We'll come back to the feelings point of view. We must express, we must be heard, even as the experts, give us the details. I think there are 2 things to separate here, Latif, and I think one is our own capacity to not only deal with this in that kind of eventuality, and then the next is why we're inviting Ebola. All right. Are we inviting Ebola? All right. That's the. Are we inviting Ebola? That's because we have this capacity. We have Prof. So Ebola should show up in this land. Is that what you're saying? Feelings, guys, relax. We're coming. Please.
Thank you so much. Stephen Aricha is my name. I currently head the Genomics and Molecular Surveillance Unit at the Ministry of Health. So I also want to weigh into the conversation that we've just had about our preparedness. Yes, I'm a proponent of the yes, like we are prepared as a country, and what you are seeing around is a sign of how prepared we are. If I can speak in terms of the laboratory, we have the national laboratory, national reference laboratories, which is under the division of the the Division of National Laboratory Services. So this is an institution within the Ministry of Health that is charged with the responsibility of advising the ministry in terms of diagnostics and also offering policy directions in terms of how we are supposed to do the testing. So what I can say, as my colleagues from KEMRI have spoken to, like, we have the capacity, we have the personnel, we have the equipment, and we can be able to tackle and test Ebola. And just in case, I think there are different levels, and I want us to understand those levels. Screening is not testing. Screening is different. So it starts with screening, and you are seeing this happening at the points of entry and at communities and all border points. Then there's also the testing. Testing is done at the lab, and so far we have 4 designated labs that are testing currently. We have the National Public Health Laboratories under the National Virology Reference Lab, where the testing and coordination is done. So all the samples come to the National Public Health Laboratories, from where now they are given to these other labs for comparison. Because remember, for you to give a test and confirm, it has to be compared between 2 labs, what we call lab-to-lab comparison. So that is one. Then we also have KEMRI, 2 labs, KEMRI Nairobi, and then KEMRI Kisumu. And then we have also a mobile lab that can be given to N hotspots, and then testing is done without necessarily transporting the sample from the point where you have a suspect to the national reference labs. So I think we need to demystify this, that the country is not prepared. It is prepared, and you can be able to see that from the screening, from the rapid response teams going to the counties, to the testing.
Let me ask the question, Stephen.
Yes.
The concern comes from just the basic understanding of, for example, the establishment of the US-funded facility, okay? That if somebody is tested and they are found to have Ebola in the DRC, they'll be put on a plane and brought to Kenya for treatment. Is that importing Ebola?
I think, Ratif, what we should be discussing is, when we have a case in the country, how do we handle it? As opposed
so
to...
let's ask this way, okay?
As opposed to...
Let's ask it this way.
Yes.
Is getting a patient who has been confirmed to have Ebola in DRC being brought for treatment in Kenya, let's even say that patient is Kenyan, is that importing Ebola?
It depends from which perspective you are looking at it. But if I was to answer the question straight, this is not a case that is within. So if we have a local case, that's a different story. But if a case is originating from a different country, that is a different story.
I think, can you frame it? I mean, you can give the prof the microphone. I think the public is interested with answering this question, that these cases are going to be flown here at Laikipia Air Base, and it's fantastic that we can, quarantine it and do whatever it is. But as a public health question, this case was far. It was in Zaire, or whatever you want to call it, but now we brought it close. Does that increase the public risk of us contracting Ebola, or Ebola getting or seeping into the country? I think that's the question we're asking.
I think I'll answer.
Okay. So thank you very much. First, I don't want to focus on the Laikipia facility. I want to assume that we are not talking about Laikipia, because people will get emotional when you talk about Laikipia, because information has gone out there and they're saying certain things, okay? Let's assume that it was not Laikipia, but it was Kenyatta National Hospital.
Yes.
And Kenyatta National Hospital, we know that there's a designated area for dealing with Ebola cases. If a person came out, let's say it's a Kenyan, because we must treat our own Kenyans. There's a Kenyan who's gone to DRC to do business, whatever it is, they have gone there. They fall sick, they have to come back home. And you take them to this facility in Kenyatta National Hospital, which has been set aside to be able to deal with this. The question you're asking, is that an importation of Ebola? So for me, I want to say this, that number one, by the time you're bringing this person from DRC Congo and they either have been confirmed or there's a very high suspicion index that this person has Ebola, all manner of precautions are in place. The way they're going to be transported is not the same way you would come on a plane or in a bus. You're coming under special conditions. When you come here, they have already prepared for you. So everybody's prepared. They're wearing their PPEs. Everything is in place. The likelihood of you, and you remember, Ebola is not like COVID, which is spread through air. Ebola is through contact, and it can be direct contact or contact of soil, if you have soiled clothes, either through vomiters or through stool or through any of those bodily fluids. Or if I touch you and you've got blood and other things, I will get it, okay? But if all these people have actually taken the precaution and they have the PPE, they have transported you properly, and they are bringing you into a facility that is already prepared to receive you that way, the likelihood of you getting that Ebola is very, 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 very low. In fact, I would also almost say nil, because it is not airborne and they have taken all those precautions. And let's assume this person comes in and probably they are very unfortunate, they die. Kenya is one of those countries where we have systems that work. And this happened, and we saw it during COVID, whereby even people who died in Mombasa were buried in Siaya through a chain of custody. This person who dies in that facility, if they died, they will be buried according to the laws we have. We have a Public Health Act in this country that actually helps prevent things like that from going haywire. So it is highly unlikely for me to say that a person who has come from DRC Congo and they were properly brought in, and that they will actually spread Ebola to the rest of Kenyans. I worry about people who may get Ebola, they come in and nobody knows, and our system,
and even they don't know.
And they don't know, and our system don't detect it. Then they can have the capacity or the opportunity to actually spread it. But a person who's already known and is coming in and is coming into a specific facility where we have the systems already working, it is very highly unlikely that we can actually get an infection from that. Therefore, I don't consider that as an importation of Ebola that poses a risk to our people in the country.
Peterson, you'll answer this, but I think I like what Prof is saying, because you're talking about picking a patient in a highly contained system to a highly contained facility for treatment. And therefore, you're basically saying you're reducing the chances and the risks of transmission. Yeah. Everything is being managed. Now, do you think if we said this, there will be trust that, now it's okay then. So if that's the case, do you think there will be trust? But Peterson, as you answer that question, because now you and your clinical officers are in all these facilities, right? And they're dealing with the people on a daily basis. Do you think that they'll take that information and be like, at least now I know?
I think let me start by saying that the conversation I've had, there is this notion that you can close out Ebola. You know, there is this notion that if you're bringing some people in for quarantine, then you're bringing in Ebola. And if you don't, we are going to close it out somewhere outside our borders. In a pandemic, you cannot close it out. And I think Prof has said that no matter the kind of screening you do, people who are infected can still come into the country. And especially because you have 3 weeks from the time you are infected, when the person who was infected does not know they have the virus, and the screening mechanisms cannot also pick them. So somebody can actually walk through that airport, through that point of entry, and come into the country, and probably only after 2 weeks, 2 weeks after, they are going to probably suffer some symptoms and probably go to a local clinic. And let me explain this using a scenario. You know, we have many young people from DRC who are working here. And you don't know where they're coming from, where they're coming from South or North Kivu or Ituri province, where this is endemic. And then this person might have gone home because probably a relative was sick or they were going to bury them. And when coming back, some mischievous people may declare themselves as coming from another province or from Kinshasa or not having traveled. Or actually, they can actually give out the information, but they are in that stage. So they may be screened, probably followed up. Some may be lost to follow-up because in surveillance, then you're supposed to, if somebody is a suspect, they were in an endemic area, you are going to follow them for at least more than 3 weeks. And the Ebola disease have several phases. There is the first one, the incubation period, about 3 weeks. We have the second one where you have the dry symptoms, the ones Prof talked about. You're having similar to malaria and typhoid, dizziness, headache, muscle-aches, and whatever. Then depending on the strength of your immunity, you are going into what we call the wet phase. The wet phase is where you are most infective because you're having vomiting, diarrhea, excessive sweating, temperatures more than 38.5, and then later now, if that is not managed, you may get into the hemorrhagic part. For the many patients that we attended in West Africa, most of them actually died without even getting to the hemorrhagic phase. They died of hypovolemic shock due to vomiting, diarrhea, they lose water, and you go into shock. And if you can have aggressive supportive care at that point, you can actually save these people without even the expensive drugs, because we never had any expensive drugs there. It was just volume replacement and electrolyte replacement. So understanding this, then you understand that actually somebody can be infected, come through that airport, get into the community, and because themselves they didn't know, the moment they fall sick, they will appear into that local clinic.
Yeah.
They'll meet a nurse or a clinic officer. If they are not trained, if their index of suspicion is not high, they are going to treat them. Probably if they don't give the history of where they are coming from, treat them for something else. Then they don't get well. They'll come when they are worse. And by the time you are knowing, they have infected the health worker. The health worker has infected their families. So that is how you start a community spread. And that is why Prof is saying, for us as health workers, we are very okay. We feel very safe when you're in quarantine, when you're in isolation. We already know. And we know we have contained you. We are more worried about who haven't the surveillance picked. And that is where I was coming from, that there is a way of objectively actually assessing our preparedness. We have several pillars that you need to employ during an outbreak. You have what we call risk communication and community engagement. You have surveillance and you have epidemiological response where you have contact tracing and what have you. You have the case management where now you have isolation and quarantine and you're managing these people. Then you have the safe barriers. And these pillars will be employed at different stages. where we are today, we do not have a case. And so what we must aggressively do is the first two pillars plus the diagnostic capacity. That is risk communication and community engagement. And that is where we are failing. And I think the question was probably asking adequate or not adequate. And I would say that I think there needed to be another part of it, because what I can say is that currently we are not adequate, but not that we don't have the capacity, that we need to work to ensure that we get that adequacy. And what do we need to do? When you talk about risk communication and community engagement, when we want that case that I talked about in the community, how do you get it? You need to have educated the populace to be able to pick some of the symptoms and report. When they report, it's taken up by the surveillance team and the experts we do have. When it's taken up by the surveillance team, then they are going into a quarantine, and the diagnostic side now is going to test and confirm that actually we are having a local spread there. And then the case management moves in. These people are quarantined. Once they're confirmed, now they're isolated, and they can be able to be managed.
So the first thing we need to do is make sure that the public is on high alert.
And that is where we have failed.
And that is not happening. That is not happening. And that is where the problem actually is. So we are asking the wrong question and answering the wrong question.
And just to finish,
summarize what you're saying.
And just to finish, because we usually say facts over fear. What we are seeing from the community now, it's a reaction from fear. Why do they have fear? It is our mistake. It is the mistake of the government that as experts and as government, we have not come out to educate the people so that they understand how they can protect themselves, they can be able to pick this. But if we give them the facts, and I'm very happy we are having this conversation, then once they get the facts, the fear is going to go away. And then we are going to probably have a more sober conversation about this. And you need a whole of society approach when you're dealing with an outbreak of the level of Ebola.
All right, where's the microphone on this side? Please, then to the ladies in front. Go ahead. You have a minute.
Okay, good evening. My name is Logo Alokwe. Actually, I'm starting to get relief, having heard from the professionals here. But even as they have said, do we still have, so is it okay to say that the facility that is being built here in Kenya, maybe that is being funded by the US government, do we have to say that it's still okay to bring such kind of facility for other countries, or is it for Kenya? That is also a problem that maybe most of the Kenyans are not understanding. Another thing is that the way they have said that Kenyans are reacting from a point of fear because we were not well rather equipped. Some of us we are undergoing what we call mental distress because of fear. We've seen that what's happening in Laikipia for that reason. Another thing I want to say is that as much as we are saying that we have the facility, or rather we are capable of containing Ebola, do we have the facilities like to contain Ebola alone? Because we've seen that it is being built for in Laikipia to contain other cases.
Yeah, Prof said that we have facilities. Did you listen to the Prof?
Yes, I did.
Yes. You're not convinced?
I'm not yet convinced. You know, they are working for the government. They have to be politically right.
Okay, yeah. Please pass the microphone to the front, please, to the ladies. Yes. Yes.
Okay, hi. Hilda Ndambuki. So I still don't think that the country is prepared enough for Ebola because, first of all, they've said they only have 4 test centers. So if we get a case in the hospital, because they've said the Ebola cases don't present as hemorrhagic, they don't bleed fast. So we have it can be confused like malaria. So when we get patients with those symptoms like fever, vomiting, and diarrhea, like, do we send them to the test centers or do we just manage them as malaria cases? Because I kind of think that we're not prepared. And apart from that, no one in the community knows the Ebola symptoms. All of them just think that it's just bleeding. So if they just get Ebola, maybe they have a relative who traveled from Uganda and they probably just interacted with them. So they might have Ebola, but they won't know. They will just spread it to the community, and well.
Is that what Peterson is saying, that we have not done a good job of public awareness, that the community is not aware? Maybe communities along those border points, like I saw in our bulletin tonight, the community around Busia at the border crossing seems to have a bit more information. But how far, how many kilometers inside Busia would that information spread? Let's hear from you.
Thank you, Eric. Brenda Oloch is my name. So my question is politically sensitive, but we are here to inject. So
go ahead, Brenda.
We had the High Court of Kenya ruling that the establishment of the quarantine facility in Laikipia should be put on hold for further hearing. And with the information shared here by the experts, make me question the evidence that informed the High Court ruling, because what they are saying is that the country is adequately prepared. And then on the other end, us, the emotional citizens, I think that we can't be exposed to this virus. So this makes me question, so was the High Court ruling made on without facts or science? That's why it was made that way? Or was it because of the citizens are pro? So before decisions are made, what consultations are done? Yes.
Okay. Brenda, that's a good one. It's the court has just said, halt this as we hear the case. The Attorney General is supposed to come with a response from the government side on everything, right? And in fact, today, Justice Nyaundi has asked for specific details. Give us the details of this particular facility. But remember, it's on that facility, and saying no other facility that has international support should be established until we deal with this one. Doesn't stop Kenya from starting a facility.
No, absolutely not. And to be clear, the General has not responded, and up to, I think, this evening, the government has not given any responses to this. Yes, please.
Thank you so much, James Max. My name is Dan Kanotieno. I am a recent graduate of the University of Nairobi, Medical Lab Science. I want to take a different tangent from what my seniors have said, and this is how I think. I'll talk statistics. Between 2014 to 2016, 815 healthcare workers contracted Ebola. Yes? And then we are told that healthcare workers, because they are at the forefront, have a possibility rate of between 21 to 32%. They are more likely to get Ebola. Now, my question is, the higher you go, do you lose the sensitivity of that? Because these are not just healthcare workers. They are people with families. And should we put that aside and say, you know what, we are ready? Other question would be, what if we get overwhelmed? Yes, our experts are saying that Kenyan public health infrastructure is so good. But what if we get overwhelmed? Latif, let me tell you, no one is ready for death, and we are playing with death. We've heard that this is a new strain. It's called Bundibugyo. And this one has a mortality rate of more than between 30 to 70%. So that means that for every 100 people infected, 30 people die. These are not just statistics. These are brothers, these are sisters. And that is what I'm asking my seniors. The higher you go, do you lose that sensitivity of saying that, of course, we are now academic, but we are putting all this aside and saying our systems are very strong. But we've seen Sierra Leone, Liberia. They were overwhelmed. All right?
They had weak systems.
Yes. All right.
Mutunga told us those guys had very weak systems.
Yes.
Because of their history as well.
Also, healthcare workers, they die because of lack of PPEs. All right, the US, formerly in 2015, and that is where we are getting the difference. In 2015, the US was part of the World Health Organization, and it was hugely funding it. That's why there was a lot of response and going in. But right now, the US is no longer doing that. The US is now focusing specifically on Kenya, Laikipia, and its own citizens. What about Kenyans? All right? Thank you so much. Dan Kanotiano.
All right, so answer that, then I want to go to experts. I hope you've gotten these questions, right?
Thank you so much. My name is Alex Karoki, a youth leader from Laikipia County. So, ladies and gentlemen, you have asked two main important questions. One, is the country prepared to tackle Ebola? In my own opinion, the country is not well prepared because this is a new disease. We have never had a case of Ebola in our country. So fighting a new enemy is rather very hard. So I think the preparedness of our country is very low. You asked another question about importation of the disease. In my own point of understanding and basic understanding of importation is bringing something in the country that does not that does not belong to the country. So bringing patients from wherever they come from, either DRC or Uganda to Kenya, is that not importation of Ebola? Higher. On the other side, I want to tell the government that the people of Laikipia have spoken. And the people of Laikipia, being one of them, have spoken through action and words. We do not want an Ebola facility in Laikipia. Yesterday, the president said that he is the one who gave the permission to start the facility. I want to ask our leaders, we, the people of Laikipia, have we been involved? They say that they did not bring the facility with malicious intentions. I want to ask them, if yes, or if it does not have any malicious intention, take the facility to State House. I think the State House is more secured. I think the State House has a large area where they can build the facility, or else take it to Parliament. And we will know that the facility is not there to, it is not a malicious thing. But for where I stand now, as a representative of the people of Laikipia, we do not want a facility of Ebola in our country or in our county. If ever it will be brought, let it be set up when the country is suffering from the disease. But for now, we do not want anything to do with Ebola facilities in the country.
So, youth leader, let me ask you.
Ask me.
Are you saying that you'd be okay with the establishment of a facility if there's a confirmed case in Laikipia?
If there is a confirmed case in Laikipia to treat the people of Laikipia, then it is okay. But bringing people from other countries to Laikipia, what is that? Laikipia is a county where we receive tourists. What have you done to our tourist destination? You have totally destroyed our county. You understand me?
Okay. What if it's a Kenyan who is brought to Laikipia?
A Kenyan from another country?
Yes, a Kenyan who gets Ebola. A Kenyan who is from Laikipia, but who has gone, like Prof said, who has gone to DRC and they got Ebola.
If a Kenyan from Laikipia, and I pray that we do not have any patient from Laikipia, gets the disease either from Uganda or from DRC Congo, let them be treated in the country until when they are free from Ebola, we'll bring them back to the country. But before they are free from Ebola, let them stay in the country where the disease is being treated. Therefore, the country has better understanding of the disease. Until when they are virus free, they will come back to the country and we receive them in our country. Okay. Period.
If we extend that argument, if there was a confirmed case of Ebola in Nairobi, you're in Nairobi today.
Yeah, I am.
You're from Laikipia.
I am.
Will you go back home?
Of course, I love my people from Laikipia. I will not go back to home until I stay for around 2 weeks. We were told that the disease takes around 2 weeks. I cannot go to kill my village people at home. I have to stay in Nairobi until I am sure that I'm free from the virus.
Right. You've not taken any comfort from what the experts have said about justice facility, that the experts would take care of the patient, they'd be transported in a very safe way into the facility and treated so that they're not being essentially launched in the community. You've not taken any comfort in that knowledge?
I don't see the sense of bringing people from DRC. Am I thinking differently from you people? Is there any sense of bringing a sick person from DRC Congo or Uganda to a country that does not have any confirmed case, a country that has never, ever dealt with Ebola? Does it make any sense?
Right. Please bring the microphone at the back to the epidemiologist to help us. He has answers for the youth leader.
Okay. I will not touch on the Laikipia issue. I will touch on what this guy was asking. No, there's a guy from University of Nairobi who asked a question.
Yeah.
And he gave some numbers. I like numbers because also I'm a medical statistician. You gave numbers of the people who have died in the forefront, the healthcare workers. If we check this current outbreak, after they reviewed, the first case suspect was around 24th in April. But it was detected 15th of May. How many days are those? Close to a month. Now, in that span of days, that is what we call the index case. That's where many healthcare workers die because they don't know what they are treating. We're saying we went as 171 to Liberia. He admits that the system was overrun. Ebola was running after people, and we ran after Ebola until we took that Ebola to gates of hell. So why are you doubting us? Because yes, the system was overrun in Liberia. We went there and we stabilized. Within 4 months, we did have a case. And we came back. Nobody was infected. Now, there's something which is very important. Communities. And epidemiologists will always say that outbreak starts in communities and they end in communities. Very important. Now, when we have a toxic environment, in terms of giving the information, there is a high likely to have two things. One, misinformation, then disinformation. Now, both mean the same, but one is deliberate. Let us not politicize this thing. Because once you have a toxic environment in terms of response, I've said outbreak starts in communities and they end in communities. Let's not politicize everything because Kenya, I think the internet connectivity is around 70% or somewhere there. We have informed population, but if we give them the wrong information or we divert from what is important and it becomes a Laikipia issue, like it's not really Ebola, let's focus, let's help our communities understand what is Ebola. And the Gen Z is here. I'm sure you have not traveled wider. If you go to some of these countries, you will appreciate what we have as a country. I worked in Iraq sometimes 17 years ago when there was the war in Iraq after Saddam was hanged, there was civil war. Those weak systems create environment for these things. I was in Liberia, I saw the issue. So let us not be toxic. Let us get the real information from the right quarters. And everybody has opinion, and it matters. But when it comes to outbreak, it's like propaganda in war. When you have a community which is not cooperative, it is extremely difficult to control the disease. So I would urge, when we are talking, let's get verified information from authorities. We have different areas where this information comes from. He is here. He's a professor. I'm a student of PhD in his Cambridge. And I trust him more when he says than any other person, because he is an authority in this. Let's listen to what you are saying. It's good to have your own opinion, but let's not make the communities start divert from what it is there, because any information you will send will be diverted, and it will turn out to be mostly disinformation, whereby it is a deliberate wrong information. Yeah, thank you.
And allow me to also contribute to that for a moment.
As we wind up, Peterson.
Yeah, it's good that people understand where we are coming from. When we saw what the country was discussing, because the people we were with in West Africa, we actually have a group. People were really concerned that we were taking the wrong direction. You know, like in Sierra Leone, what fueled the quick spread of the virus is politics, pure. Because where it started was a predominantly opposition zone, and they believed it was the government trying to eliminate them. And at some point, they were saying that the government has brought this. When you go to the facilities, then the health workers have been instructed to kill you. And so the role of politics. And that is why we agreed, and that is why we keep on saying that for us, we want to be that objective voice. We are not here to support the government. We are not here to support the deals, the bilateral agreements. We are not here to support the opposition. We want to stand as experts and guide the country. And our biggest fear is there are two things that we are seeing from the politics, the stigma. And now, you know, Kenyans think that quarantine facility is such a bad thing. But then we have quarantine facilities where Kenyans are being taken. And if we are not going to counter this with facts, so that the people understand that actually a quarantine facility is meant to protect the community, it's safe for the community, then we will have people of Mbagathi saying we don't want a quarantine in the National Police Service Hospital. We don't want a quarantine in Kenyatta National Hospital. So as the people who have been to the ground and who have been able to manage this, we want to stand in the gap to be that objective voice that now informs the community and makes them understand that when you are faced with a threat of the level of Ebola, you know, this is not military where you can shoot. We must come together. It doesn't matter on which political side you are on. We must all mobilize, we must come together, and we must face it together.
Yes. Prof?
So I want to respond to the concern by the young lady. It was a question about are we prepared or not, and she said because Ebola presents like malaria, especially in the initial phases, then we are unable to tell the difference. And we may be saying that somebody is suffering from malaria and they have Ebola, and therefore we are not prepared. But I want to give you a detail that you may not know of what we do in the laboratory. When you bring a sample to the laboratory, we have information about the symptoms that are associated with that and all the diseases that look like that. So if you come to our labs in Cambridge, if you ask a question, is this person positive for or negative for Ebola? In other words, do they have Ebola? We'll say they're negative. But we'll not give you the details of what we did in the lab. Mm-hmm. So when we do a test in the laboratory, we do not test only for Ebola. And in fact, when we test for Ebola, we test for all the known strains so that we can tell you, yes, it was Ebola, but it's Ebola Zaire. It was Ebola, but it was Ebola Bundibugyo, or it was Sudan, or Reston, whatever it may be. So that's about Ebola. But I want to tell you that we have a group of diseases called viral hemorrhagic fevers, which we test for all of them. Congo Crimea hemorrhagic fever, Rift Valley fever, yellow fever, Ebola, and all of them. So if you look at my detailed report of what it is we have tested, I'll give you a report to talk about whether this person was Ebola positive or negative, because that's the question you asked.
Yeah.
But if you ask me, what else did they not have, or what else did they have? Then I have a whole catalog of things I say, we tested for the following 15, we did not find any. Or we tested for all these 15, we found malaria. And that's the reason why we are saying that there was once a person who was very sick and presented with classical symptoms of Ebola, and everybody was scared. When they brought the sample to Kemri, we were able to test for all those things, and we found that it was actually malaria, and he had very high viremia, parasitemia, meaning that he had a lot of those viruses in his system. And they were being quarantined, giving supportive care, doing all those things we do with Ebola. Yet they needed malaria drugs. You know what I'm saying? So what we do is that we don't test for one thing. We test for very many things. And therefore, when we say it's Ebola negative, that's a shortcut of what you wanted to hear, but we have a whole list of it, and we probably tell you, we think he has this, but not Ebola. Thank you.
Asante.
Okay. Okay, yes. One final comment.
Just to add to what Prof said and what Mutunga said, one thing that we should also know is that diseases don't need visas to get into a country. They'll get in through people without you knowing. The other thing that probably to the lady is that we have something we call case definition. So by the time you're getting, and this is what is used when the screening is being done. So you could find somebody who has, who has fever, vomiting, diarrhea, and all that. But if they don't meet the case definition, in this case, coming from where an outbreak has been reported or coming in contact with somebody who has been confirmed, that may not really warrant us to test for Ebola. So there are things that we look at before we even say that, okay, take a sample to go rule out Ebola. So that's probably what I would say. Thank you.
All right. Unfortunately, we're running out of time. We can spend the entire evening discussing Ebola and its symptoms and how it presents. And if we're a toxic country that allows Ebola.
Are we being emotional
about this?
About this.
Yes. So before you finish, I think this has been very educative. Thank you very much to the professionals. Please come again and again to help the public really, consume this information so that we can make informed decisions. It does not excuse the mismanagement of the politics of this, which has been on high gear. And I think this is where we are and the problem that we have, because this is the first time the country is incredibly engrossed about this question of, are we getting infected with Ebola? What's happening with my community? What will happen tomorrow? It's largely a fear that is unfounded. It's a political question more than I think it's a scientific question.
Oh, yes, indeed. I completely agree that the problem that we have in this country, not just with Ebola, even with COVID and with the finance bill, with everything, is we are at a level where we are a very low trust society. We do not trust the government. And several governments have led us to where we are now. It'll take quite a lot of effort for government to actually start clawing back and have a citizen that trusts when a government says anything. The president comes to explain and people are like, it doesn't matter. We have to get to that level where the government understands that communication is its best tool to deal with any issue. Be the first ones to communicate. Let us not hear from Marco Rubio communicating and then you come to react. Let us not hear from other quarters and then the government reacts. Government should be on the forefront in sharing information and not treating citizens as enemies of information. The way that people will walk the journey with the government is when the government comes out with information. If we go to the community, like Peterson said, and start educating people, this is what Ebola is, this is what we look out for, these are places you can go to, this is the screening that can happen, the community health promoter or the local dispensary or health center. This is the information that is needed at community level. Beyond this Ebola, into the next issues of governance, if a government does not deal with communication and trying to rebuild trust with the population, we're going to end up with this. People will say no to Ebola. And like the experts are telling us, you cannot say no to Ebola. It will decide whether it wants to come or not. You have to put in a lot of surveillance and a lot of work for you to deal with that. And that is the information bit. That's the last word. Thank you very much for watching. See you again next week on Tuesday. Have a good evening.